Okay, well, I think we'll make a start today. Good day, everyone, and welcome to pediatric teaching. I wanted to talk about common kidney diseases in children, partly because there actually are common, and I think that in many parts of PNG in the Pacific, some kidney diseases are becoming a bit more common at the moment, and also we don't talk about them very much. So I'm going to talk about just the common ones, particularly nephrotic syndrome and post-streptococcal glomerulonephritis, and then we'll spend a bit of time talking about complications of those diseases, especially the way we manage hypertension and also chronic kidney diseases. So I'll talk a bit about chronic structural kidney diseases, so we've got a good overall picture of renal problems in children. But first, I wanted to start with a case, and I thought this case was very interesting. It illustrates how severe kidney disease can be sometimes, and also how we have to think widely about the different causes of kidney disease. So I'm just going to briefly, in the first couple of slides, present this case that I thought was really interesting. A young girl that I looked after recently. She was a 14-year-old girl. I hope everyone can hear me. Yeah. This was a 14-year-old girl who had about a week of severe headache and vomiting and fever. Her headache was very bad. It was a frontal headache. She had some visual disturbance as well. And then she presented lethargic and poorly conscious, and she had some meningismus. So it was presumed that she had meningitis. And in fact, she had a lumbar puncture, and that showed that she had staphylococcal meningitis. Now, this 14-year-old girl, had a history of diabetes. She had been a diabetic for about 5 years, and she grew Staph aureus on her blood culture, and it ended up being MRSA. So it's not uncommon for children who have diabetes to be at risk of staph infections, and sometimes they can be at risk of getting MRSA or methicillin-resistant Staph aureus in the community as well. And that's common in PNG, and it's also common in other countries as well. Now, this girl ended up having a complication that I think we're seeing quite a bit of at the moment. Children who've been positive for COVID and they have an infection and they get a venous thrombosis. So that combination of things was what she had. Anyway, she had staph meningitis, and she was started initially on flucloxacillin and gentamicin, and then because it was found to be Staph aureus, MRSA, vancomycin was added. And she received oxygen and supportive care and close monitoring, and things seemed to be going well. But then within a couple of days, she became oliguric, passing only 60 mils of urine in a 24-hour period. Now, I want to pause for a moment and talk about what oliguria means, because it's something we don't always think about too much, and we don't always have a way of defining. But oliguria is less than 0.5 mils per kilogram per hour. And so a 50-kilo child, as this 14-year-old girl was, should pass 25 mils an hour or 600 mils per day. But she had only passed 60 mils in a 24-hour period. So that's severe oliguria, almost anuria. And this is what happened to her creatinine. I've just plotted her creatinine level and her urea level on the on this graph, and you can see how much her creatinine level rose, almost to 1,000 and almost to 900 creatinine level rose, and this was over several days. So over about 4 or 5 days, the creatinine level went to nearly 900. It peaked at these are the normal values, so 30 to 80 micromoles per liter, and urea of 2 to 6.5, and you can see her urea rose to about 50, and her creatinine level rose to 900 over those 4 days. And I think this is a useful case, because it taught me that what we have to do is think about all the different causes of acute kidney injury. And this child, like many, had been exposed to several things that might cause a kidney injury. And when I went back on the history, when she presented, she had dehydration and from her sepsis, dehydration from sepsis, and so there's some hypoperfusion of her kidneys. she'd been exposed to vancomycin and gentamicin at a time that her creatinine was going off. And the combination of those two nephrotoxic agents probably were the main factors. She'd received ibuprofen or Nurofen for a headache, which is a normal thing to do, but that also can have some effects on renal blood flow in a child who's hypovolemic and has other nephrotoxics on board. And then she'd received intravenous contrast for a CT of her head to look for the thrombosis. So the point is that renal failure in acutely unwell children is often multifactorial, and we have to look for all the different causes of renal failure, and we have to try to minimize the nephrotoxic drugs that we expose children to if they're at risk of getting kidney failure. She was managed over a period of a couple of weeks, and you can see that her creatinine slowly went down over time. She actually didn't need dialysis, and that was another important lesson. I thought that usually when the creatinine's getting up this high, you would think the patient will only survive if you give them dialysis, but actually acute kidney injury from these nephrotoxics and the sepsis, if you manage it properly, will get better over about 6 weeks. So you'd expect the kidney function to get better over 6 weeks, as it did. And sometimes these children will need dialysis, but sometimes you can manage them without. And the way that such children should be managed is with careful fluid and electrolyte management. And so if a patient's dehydrated, you have to correct their dehydration, but then only give them the fluid that their insensible losses. I'll define what that is in a moment. You have to monitor their acid base and their potassium very closely, because hyperkalemia is an urgent indication for dialysis. So the indications for dialysis are if you've got severe hyperkalemia, so a potassium of 5.5 and rising, despite everything else you do. And there are other things that you can do to lower potassium levels, which this girl needed from time to time: sodium bicarbonate, insulin and glucose, and salbutamol. They can all lower potassium levels, and you have to think about when you would use those medications to reduce potassium in a child who's got renal impairment. If their pH is going below 7, then they need to be dialyzed. If they've got such severe edema that you can't give them any fluid, so any nutrition, remember this is going to last 6 weeks, then you can they need to be dialyzed. So you can introduce some nutrition, some enteral nutrition. Or if they've got uremia with reduced conscious state, and this child's conscious state was impaired by her staph meningitis, but it improved a lot after treating that. And then she got over her renal failure very slowly over a period of 6 weeks. And then the careful use of frusemide, and by careful, I mean that sometimes we have to use quite high doses of frusemide, but remember that frusemide is a nephrotoxic agent as well. And so we really have to be very careful about using it at the right time. And sometimes while the creatinine's rising, if the patient's still passing urine, then you don't need to use frusemide. But if they're anuric, then using frusemide to ensure that they still pass urine, it's very helpful to have a child with renal failure who's still passing urine, because it means you can still give them some fluid, some nutrition. But if they stop passing urine altogether, then you won't be able to give them any nutrition. You won't even be able to give them their insensible losses. So to maintain some urine output, I usually use frusemide, but only do it when you've removed all other nephrotoxic agents as well. So aminoglycosides particularly, and don't give more contrast in CT scans, that sort of thing, in a child who's got kidney injury. I said I'd talk about what insensible losses are, and this is important because we often say the words, but we don't always know what it means. The insensible losses are the transepidermal diffusion of water that goes through the skin, and it's lost by evaporation. So we're sweating all the time. We're losing water, not just sweat, but just losing water by evaporation from the skin. And then we have evaporative water losses through the respiratory tract. Because we're breathing, we are breathing out water all the time. And the amount that you need to give to replace insensible losses in an adult patient, this girl was almost an adult 14-year-old, it was 800 mils per day. So her total fluid intake had to be reduced to 800 mils a day And in a child, it's about 30 mils per kilo per day, of course, up to 800 mils, but 30 mils per kilo per day in a child. That's the insensible losses. So nothing like the 100 mils per kilo per day that we think of maintenance fluid. Insensible losses is less than a third of that. So that's how we need to manage their fluids. And you can give that, if you've got a child who's still passing urine, you can give that much 30 mils per kilo per day as enteral nutrition. Don't give it as intravenous fluids, because that's wasted fluid. There's no point in giving intravenous fluids. Give it as enteral nutrition because it provides some nourishment to the child. Right. So I'm going to talk about 3 common kidney diseases. I've talked about how to manage kidney failure, acute kidney failure, but I'll talk about 3 common kidney diseases and we can go from there. So first of all, nephrotic syndrome. Secondly, a disease we're seeing a lot of at the moment, post-streptococcal GN, glomerulonephritis. And then if we get time, we'll talk about some chronic kidney diseases in children, particularly the chronic structural kidney diseases that you need to know about. So nephrotic syndrome, I think you all know this, but the diagnostic features are heavy proteinuria, hypoalbuminemia, and edema. It's usually generalized edema, of course, not focal. The most common cause of nephrotic syndrome is idiopathic. When you look on if you do a biopsy of the kidney, you find what they call minimal change glomerulonephritis. It's the cause is not at all clear. There are some other causes, which I won't talk too much about, but lupus and Henoch-Schonlein purpura. It's good to know about HSP or Henoch-Schonlein purpura because it's a diagnosis we can make clinically. And lupus, of course, sometimes we can make clinically, but it's rare in children, more common in adolescents, more common in female adolescents, and typically you'll see a rash, a characteristic rash with SLE, but don't worry too much about lupus or HSP, just focus on minimal change glomerulonephritis, which is the cause of nephrotic syndrome. Many children with nephrotic syndrome, even though they're edematous, they can still be hypovolemic. So we need to be aware of that. And sometimes they present when they've got infections, particularly intra-abdominal infections. And sometimes they present when they've got thrombosis. So these are the acute complications that we need to always look for: hypovolemia, infection, and thrombosis. Now, about 80% of them will be steroid responsive, but about 80% of them will also have some relapse. So they respond to steroids and then they may have a relapse some months later. Eventually, they usually get better if you manage them well, but you need to be able to measure whether they are steroid responsive or not, because some children won't be steroid responsive and it's pointless just giving them steroids, but most of them are steroid responsive. But before we talk about nephrotic syndrome, I think it's important to go back to the differential diagnosis of edema, because not all children with edema have nephrotic syndrome. And I think you know this as well, that there are many, many causes of edema, and you can break it up into those that are caused by hypoalbuminemia, for example. So kwashiorkor, there's hypoalbuminemia because there's inadequate protein intake. There's other causes of protein loss, including nephrotic syndrome, but also you can have a lot of protein loss from enteropathy, so from the gastrointestinal tract, and that can sometimes cause a severe generalized edema. Or if there's liver failure, where the liver is not producing protein, all the protein's made in the liver, then that also can lead to generalized edema. And then there's other conditions where you've got the right amount of protein, but you've got fluid retention. And so anemia with fluid retention, or congestive heart failure with fluid retention, or the child's been given too much intravenous fluid, for example. And then there's some cases where edema is related to lymphatic obstruction, and we see this in tuberculosis quite a bit. And of course, lymphatic filariasis, that's the characteristic is lymphatic obstruction with edema. But with TB as well, when you've got lymphatic caseating lymph nodes in the gastrointestinal tract, for example, or in the groin, sometimes you'll get generalized edema. And then in children who are very unwell, then severe capillary leak syndrome in with severe sepsis is another cause of generalized edema. So when you see a child with edema, I think it's important to go through in your mind, is it which of these conditions it is. So when we're considering the differential diagnosis, you need to consider, is this child sick or well? Is it generalized edema, or is it focal edema? Like if it's only one leg, for example, or just the legs and not the upper body or the trunk or the face, just that means that the differential diagnosis is different. You also need to assess the severity of the edema. So is there ascites? Is there pleural effusions? Is there a pericardial effusion? Is the child pale, suggesting anemia, or is the child jaundice? Are there other signs of protein energy malnutrition, other signs of kwashiorkor, for example, or other signs of TB, or signs of lymphatic obstruction, like large lymph nodes, for example? Or is there a rash related to SLE or Henoch-Schonlein purpura? This is Henoch-Schonlein purpura. It could be meningococcal disease, but it's a child who had Henoch-Schonlein purpura, and you can see the characteristic rash, which is usually on the legs, particularly on the buttocks and the backs of the legs. But it looks like this. The child's usually not very unwell, whereas if a child had meningococcal disease, they're typically more unwell. They often have abdominal pain though, and vomiting and bloody diarrhea sometimes, and they're likely to have this rash, a non-blanching purpuric rash, right? Now, of course, this is always, you should always think, could they have meningococcal disease? But also think maybe they've got Henoch-Schonlein purpura. It's sometimes hard to tell the difference, because even with meningococcal disease, sometimes children have arthralgia, or they may have a lot of limb pain with meningococcal disease, as they do with Henoch-Schonlein purpura. Typically, the white cell count will be normal. There won't be signs of sepsis, and the child will have hematuria, and then usually not unwell. Usually you can make that distinction, but I often at the start treat the children as if they've got meningococcal disease, and then work out the diagnosis, because you don't want to miss meningococcal disease because it just gets worse quickly. Yeah. So, but this was HSP, Henoch-Schonlein purpura. So the assessment of children with nephrotic syndrome, first of all, you should assess whether they have intravascular volume depletion, because even though they've got edema, they can sometimes be hypovolemic. So if they've got cold hands and feet, or a capillary refill time more than 3 seconds, or they're tachycardic with low volume pulses, or they're oliguric, or they're hypertensive, you need to assess all of those things. They may be hypovolemic even though they're edematous. You should also make a grading of their edema. And I tend to think that children, if they've got very severe edema, then often they have edema in throughout their whole body. Look for things like skin breakdown and cellulitis. So often in the skin creases where there's edema, or in the suprapubic area, in the scrotal area, there's often where there's edema, there'll often be skin breakdown, and that can be very dangerous for children who've got severe nephrotic syndrome. Or they might have pleural effusions or ascites. These are all don't just say the child's got generalized edema, but describe the locations in which it is, and which it's severe, and whether the skin's intact or broken down. You should also look for signs of cellulitis or spontaneous bacterial peritonitis, because that sometimes occurs in children with nephrotic syndrome. And you might wonder why these children are more prone to infections. And the main reason is because when you've got nephrotic syndrome, you're losing proteins, and you're losing not just albumin, but you're also losing immunoglobulins, and they're the antibodies that fight infection. So children with nephrotic syndrome often become hypogammaglobulinemic. That is, they lose immunoglobulins, and part of the reason why they get infections is because of that. And you might wonder why they get thrombosis. Well, when you've got protein loss, you're also losing coagulation factors. So they get disturbance of coagulation factors and a hypercoagulable state. And they also get intravascular volume depletion. That is, they're hypovolemic. So they're more likely to get vascular stasis and thrombosis. So they're the main reasons. Yeah. The investigations of nephrotic syndrome, obviously you look for heavy proteinuria. It's not just a bit of protein. They usually have quite marked proteinuria. Check the urine also for blood. If they've got blood, then it suggests they might have nephritic syndrome. And sometimes, of course, there's nephrotic syndrome where they've got severe protein loss and also glomerulonephritis. The creatinine in nephrotic syndrome, it might be normal, unlike in acute kidney injury, and like the child I showed you before. The creatinine can sometimes be normal, or sometimes if they've got an elevation of the creatinine in pure nephrotic syndrome, that's because they've got volume depletion, and it can be a clue to that. If the creatinine is very high, then you need to consider that they've also got nephritic syndrome, so nephrotic syndrome. You check their liver function tests, including their albumin, and their albumin will often be very low. I've said less than 25 grams per litre, but actually it's often 15 or 12. It's often very low when they present. And check for their full blood count for signs of infection like neutrophilia or neutropenia. So we've talked about the signs of infection before, but you need to go through their full blood count very carefully and see. So basic investigations, you don't need to do too many to make the diagnosis and assess the severity and give treatment. It's useful to have these test strips, and heavy proteinuria is usually up at this very green range. So check their urine for protein. It's very useful to have these test strips if you're once you start treating, because then you can assess whether or not they're improving, responding to the steroid treatment that you put them on. And I usually try to give families a bottle of these test strips and ask them to go when they go home, so that they can assess the child's urine a couple of times a week and weigh the child. So you can teach families about nephrotic syndrome, and they can monitor their child's treatment. You have to manage their edema, so don't give any extra salt in their diet. I tend to weigh them every day, and at least a couple of times a week. If you've got the test strips, you can do daily urine dipsticks to monitor their protein. You have to have strict fluid balance and close attention to their volume status. So every day you need to address on the ward round, address what their edema is like, compare it with the day before, compare their signs of intravascular volume status or depletion. And because it's very important, you should not give furosemide if they've got intravascular volume depletion. So you have to be happy that their intravascular volume is adequate. Otherwise, you can make their shock worse. Sometimes, if you've got it, you can give some intravenous albumin with furosemide, but mostly in children with nephrotic syndrome, you try to avoid giving them furosemide. They're usually passing urine anyway, and their creatinine is usually not high. It's different to children like the child I mentioned at the start who had acute kidney injury, acute renal failure. Give penicillin V to prevent pneumococcal sepsis, so benzyl penicillin or penicillin V. While they've got proteinuria, then they're at risk of having spontaneous bacterial peritonitis, and so I always treat them with penicillin to prevent that. This is the regime of prednisolone that you can use for nephrotic syndrome. This is the international standard for the treatment of these children. It does mean there are different treatment regimes, but this is what I usually use. It's quite high dose to start with, high dose prednisolone to start with. It's 60 milligrams per meter squared per day. And a 7-year-old who weighs about 25, 27 kilos is usually 1 meter squared. That's something to remember. Most adults are about 1.5 meters squared. So you're giving about to a 7-year-old who's got who has a 7-year-old with who's about 25 kilos. They would be getting 60 milligrams per day for 4 weeks. That's the maximum dose you should give. And then after 4 weeks, then you progressively taper off. So 4 weeks of that, and then 4 weeks of tapering, and then another 10 days, 10 days, 10 days, and then you cease. And sometimes you get down to, as I mentioned here, alternate days. So this is important that after the initial 4 weeks, then you're tapering to alternate day steroids. And when you're giving alternate day steroids, you're much less likely to have the major complications of Cushing's syndrome. So after 4 weeks, taper to alternate days and reduce the dose. These children tend to develop some Cushingoid features, but not if you taper like this going to alternate days. The way to work out the body surface area, so this is 60 milligrams per meter squared. Those who have done this before, I know anyone who's given chemotherapy will have done this, work out the meter squareage. It's the weight in kilograms times the height in centimeters divided by 3,600 and the square root of that. Some of you will have done this before, but it's a useful formula to write down and to know how to assess the body surface area of children.
Hey, we'll sing happy birthday, no Wayne.
We should, when a child comes in with nephrotic syndrome, we have to, or any kidney disease, we need to think about discharge planning fairly early on, because otherwise they stay in hospital for a very long time and they they're at risk of getting infections and other things. So I always teach the family to test the urine each morning or even a couple of times a week to identify a relapse. It's really good to, proteinuria is the first sign of relapse. And after the second sign is when edema develops. And usually by the time edema develops, they've had proteinuria for quite some time. And so it's good to detect relapse before edema develops, and it's much more effective. Then you can restart steroids at usually a lower dose, and it's usually quite effective if the child's been responsive to steroids in the first place. And I always tell the parents they very likely respond to the steroid therapy, but they're also likely to have a relapse, about an 80% chance of having a relapse. And if you pick it up early enough, then you get on top of it and you can treat it with lower doses of steroids, and they do generally do very well. In any child with nephrotic syndrome, it's useful to know the features that suggest a diagnosis other than nephrotic syndrome. So you need to be always thinking, is it just idiopathic nephrotic syndrome that's going to respond to steroids? Well, if they're very difficult to control, as in they don't respond to steroids and their edema persists, or if they have very elevated creatinine, despite if you correct their hypovolemia, but their creatinine stays high, or if they're not in remission after 4 weeks of steroid therapy, then you should think it's not idiopathic nephrotic syndrome. Or if they have frequent relapses while taking steroids or within 2 weeks of steroids being treated, then sometimes you have to think, is it just idiopathic nephrotic syndrome or is it something else? Okay, so we talked about nephrotic syndrome. I hope that's useful. I wanted to speak about post-streptococcal glomerulonephritis because it is becoming quite common, a common condition, I think, because of more skin disease, probably. It particularly affects children similar to rheumatic fever and rheumatic heart disease. Of course, it has the same origin of a group A streptococcal infection. It can occur both throat infection or skin infection. So tonsillitis from group A streptococcus, or skin infections such as impetigo or infected scabies, and typically 3 to 6 weeks after that. I think I'm seeing a lot more of it actually in the COVID era, seeing children who've had COVID, they get a group A streptococcal throat infection, and then they get post-streptococcal glomerulonephritis, or they've got skin disease that doesn't get treated because they have been delayed in being, presenting to a doctor, and then they get post-streptococcal glomerulonephritis. So I think it's just on the rise at the moment, and we need to be good at managing it. As you know, it's not a direct infection of the kidneys. It's not that. It's an immune complex deposition in the glomerulus, and that activates the immune system, activates particularly complement, and which is part of the immune system, proteins in the immune system, and that leads to the key features of post-streptococcal GN, hematuria and proteinuria, and it can be as bad as nephrotic syndrome. It can reach the nephrotic stage with edema, but not always. the children are usually edematous, but the hematuria is the most the cardinal feature. They're almost always hypertensive because they're oliguric. They have salt and water retention, and sometimes the hypertension can be so bad that they have encephalopathy. That's quite, unfortunately, becoming quite common, hypertensive encephalopathy, and sometimes that can lead to a significant brain injury. And sometimes they have, a bit like the child I talked about at the start, they have an acute kidney injury with renal failure and high creatinine levels. This is the child who had post-streptococcal GN. You can see on the left, you can see the infected scabies he had and the streptococcal infection. The origin is obvious in this case, and this is another child with post-streptococcal GN, and this was a streptococcal throat infection. So it can occur with either type of infection with group A strep. This is infected scabies, and I think we all need to get good at managing and treating, identifying and managing scabies. This is if you do a biopsy of the kidney, this is what you see. So this is the glomerulus, and these are all inflammatory cells, lots of neutrophils invading the glomerulus, and these are all neutrophil infiltrates in the glomerulus. And it's not, as I say, an direct infection of the kidney, but it's a inflammatory response in the kidney. There's lots of activation of complement. You don't need to worry about that, but it's essentially an invasion of the glomerulus with neutrophils and an activation of a complement and immune complex deposition. If you look in the urine, you can ask the lab to look in the urine. I worked in a laboratory for a while where we had to do our own urine microscopy, and this is what the urine looks like when a child's got glomerulonephritis. And I want you to just look at this, because sometimes you see red cells. These are just the normal red cells in the urine, but see, these are also red cells, and you can see how they're distorted. The surface of the red cell is very distorted, and these are what's called glomerular red cells. And if there's hematuria because of an infection, because of a cystitis or a bladder infection, then there'll be non-glomerular red cells, and that is, they'll be normal shaped red cells. But you can imagine that these red cells have been pushed out through the glomerular endothelium. So the lining of the capillaries that are in the glomerulus, the red cells are pushed out through, and then they get distorted on their way out. And that's why they're called glomerular red cells. Use the investigations, you look at the urine, see these different types of red cells. Sometimes there'll be even what we call casts, which are red cells all joined together, like a cast of red cells joined together. That's another feature. The creatinine will be high, the white cell count will be high, the peripheral blood white cell count will be high, and you can measure the ASO titer, the anti-streptolysin O titer, as an indication of group A strep infection. But so simple tests: check the urine, the creatinine will be high, the blood white cell count will be high, and the ASO titer will be high. You've got your diagnosis. These are red cell casts. These are all red blood cells that have been clumped together in the glomerulus and the collecting duct of this is just looking at urine, and you can see these red cell casts sometimes. There's a differential diagnosis of post-strep GN. I won't go through it, but there are other conditions that can be associated with it. The one I would suggest that you consider is drug-related nephritis. So drug-related glomerulonephritis is, we use a lot of these drugs. So some anti-TB drugs, some antibiotics, etc., can cause drug-related glomerulonephritis. So just take a drug history when you see a child who's got, you think has got post-streptococcal GN. These patients need penicillin to treat their streptococcal infection if it's present, and you need to treat their hypertension. This is very important. If you don't treat their hypertension, sometimes they can get severe complications like seizures or a depressed conscious state or severe encephalopathy. So I try to keep their blood pressure not in the normal range. Generally, the upper limit of normal is okay. And I use a combination of medications, so using furosemide, 0.5 to 1 milligram per kilogram QID, using nifedipine if you've got it, 0.5 to 1 milligram 8 hourly, and captopril captopril, but 0.2 to 0.5 milligrams per kilogram 8 hourly. And you don't need to use all three of these drugs in all children, but for some children that have got severe hypertensive encephalopathy, this is important to use. And you should, when you see a child with post-strep GN who's had a seizure, or post-strep GN who's got a poor conscious state, or they're lethargic, make sure they don't have hypertensive encephalopathy, because you can treat it, and once you get the blood pressure under control, they're so much better, and you can treat it with fairly standard treatment. Most of these children, they start to resolve their renal impairment, their nephritis, within 2 weeks. And usually they have a normal creatinine by 4 to 6 weeks. So they generally get better. You only use dialysis for the indications that I mentioned before: progressive renal failure, acidosis, or hyperkalemia, or if they've got intractable hypertension. Usually you can get it under control with these drugs, but sometimes you need to dialyze them to bring their blood pressure down. I won't talk about dialysis today. I just wanted to talk about the other aspects of managing acute kidney problems without dialysis. Most of these children resolve, their GN resolves. Some relapse if they're exposed to group A streptococcal antigens again, just like kids with rheumatic fever and rheumatic heart disease. Sometimes they have long-term problems with hypertension, but you can usually get it under control. And then if they've got a small number go on to develop kidney problems in adult life, but mostly it just resolves. But some get scarring or glomerulosclerosis, scarring of their kidneys, and that can lead to hypertension or kidney problems in later life. But most of them, they'll resolve. Okay, so we've talked about the management of acute kidney failure. We've talked about nephrotic syndrome. We talked about post-streptococcal GN. I wanted to just spend the last part of the talk on chronic kidney disease, and only talk, there's many different causes of chronic kidney disease, but I just wanted to talk about the congenital abnormalities of the kidney and the urinary tract, because they make up about half of all cases of chronic kidney disease. And there are particularly 3 different types of congenital abnormalities of the kidney or urinary tract. And the reason to talk about them is that if we see an infant with one of these types of conditions, then with surgery, it's correctable, and they won't develop chronic renal failure. And so it's completely fixable with surgery. Now, the first one I want to talk about was posterior urethral valves. And I'm sure you know about this condition, but it's something you can diagnose clinically. It only occurs in boys. They have a minimal urinary stream, that is, they're just dribbling urine usually. They have marked bladder distension, so you can palpate the bladder usually up to the umbilicus or even higher. And if you do an ultrasound, you can see that their ureters are also dilated, their bladder is distended, the ureters are dilated, and you can diagnose it by this test called a micturating cystourethrogram, where you just put in a urinary catheter halfway into the urethra and then inject some contrast, and you can see where the obstruction is. These valves at the posterior urethra. The valves are blocking, 2 valves here, blocking the outlet of the bladder. It is surgically curable if you've got a urologist that can do cystoscopic surgery, and so it's something that usually these young boys don't have any other congenital problems. It's usually an isolated congenital abnormality. So if you fix it, then they will be fine, and if they can't get treatment, then they'll develop chronic renal failure and not do well. The second one is a little harder to treat, but it's called pelvic-ureteric junction obstruction. Again, it's just like having a small amount of tissue Like posterior urethral valves is just a small web of tissue in the urethra, and pelviureteric junction obstruction, the name implies it's at the pelvis and the ureter junction, so where the ureter comes out of the kidney, and there's a small amount of tissue, a web of tissue that's blocking the urethra, the ureteric opening. And if it's bilateral, then these children will develop a cystic dilatation of the kidneys and bilateral renal failure. Some of these kids get resolution spontaneously, so they don't all need surgery, but they all have a risk of infection because of the delayed passage of urine from their kidneys and stasis. Some need surgery and some don't. If it's unilateral, then they'll still have adequate renal function from their other kidney. If it's bilateral, then they're more likely to need surgery to just relieve that small tissue web, and that can unblock their kidneys, and then they can be fine. And then finally, I just wanted to touch on how we manage children with chronic renal failure. There's lots of other causes of chronic renal failure that you can't do simple surgery on, and they don't get better. They might have polycystic kidney disease or something else like that. And we just need a way of managing them. And I look after a number of these children, and you just have to think about the complications of kidney disease, chronic kidney disease, so particularly growth. They're usually short, they usually have short stature, and so you need to just pay attention to their nutrition and correct, if you can, their acidosis, because that impairs their growth, and correct their anemia, etc. They often have osteopenia, so they often have brittle bones, and that's because a variety of hormonal changes, and also principally the kidneys. When you've got renal failure, chronic renal disease, then the kidneys don't clear phosphate, and then your parathyroid hormone levels rise, and that absorbs calcium from bones, and you get bone reabsorption of calcium, so the bones then become quite brittle. Also, the kidneys are involved in the conversion of vitamin D3 to its active form, calcitriol, and if that doesn't occur, then the children have hypocalcemia. So the treatment is usually calcium supplements and active forms of vitamin D supplements, and sometimes you can give them what's called a phosphate binder to reduce the amount of phosphate they absorb, so they don't get hyperphosphatemia. So a lot of the management of chronic kidney disease is about nutrition and bone health. They almost all get anemic, so and sometimes they get iron deficient as well. You need to control their hypertension. I've mentioned how to do that. If you can control their hypertension, they won't get cardiomyopathy. They won't get a hypertensive cardiomyopathy, but that can be a challenge. And then try to prevent their cardiovascular complications, which all occur because of the things I mentioned: hyperphosphatemia, hyperparathyroidism, anemia, and hypertension are all lead to cardiovascular complications that occur in adolescence and adulthood. So you need to be thinking about all of these complications. So the care of children with chronic kidney disease, where you correct any correctable lesions by simple surgery if you can do it, and then try to and then recognize, I think, that it's not just the kidney that's a problem. If you've got a child with a chronic kidney disease, it has effects on many other organs. So you have to look out for the whole child. I think about nutrition and growth, bones, anemia, the cardiovascular system, prevention of infections, avoiding drug toxicity, etc. And as I've said recently, all these children need a written care plan that helps other doctors or healthcare workers look after them. So I always write out an individualized management plan for them. And I teach the family and their child about their condition. I mean, many of these children can be healthy if you look after all of these problems and make sure they still go to school, and consider that these families have quite a bit of stress because of their child being chronically unwell. So we can look after these children with acute or chronic kidney disease if we understand it well and help their families. So that's all I wanted to speak about today. I hope I'm going to stop the recording now and see if there's any questions.